Hello, and welcome to North Shore Private Hospital's virtual GP education program.
This session was recorded from a live Zoom session in November 2021. Neurosurgery in a nutshell covers trigeminal neuralgia, hydrocephalus, brain tumours, neck and back pain, and radiculopathy. Our presenter is Dr. James Laban, neurosurgeon.
To gain CPD points for the session, use the quick log function on the RACGP website. 2 points per hour to a maximum of 30 points CPD activities can be easily logged by using the quick log function on your My CPD dashboard as per below. Select Log Your CPD. A new screen will appear. Describe the activity, select the date and type of CPD, insert hours and enter Submit. The hours will be converted to points and recorded in your CPD history. There is an option to add a comment or upload documents for your own records. Any problems, please contact me, Wendy Beera, the GP Liaison Officer at North Shore Private Hospital, at gpeducation.nsp@ramsayhealth.com.au.
I'll introduce you to Dr. James Laban. He's one of our neurosurgeons, and actually, James, you can introduce yourself. I think you're going to do a better job than me, so I'll pass over to you, James.
Thank you, Andy. Yeah, so I'm James Laban. I'm a neurosurgeon. I specialise in brain, spine and peripheral nerve, particularly with spinal degenerative disorders, brain tumours and trigeminal neuralgia, as well as hydrocephalus and general neurosurgery, which I'm going to talk about tonight. So I'll go straight into it if I can. Let's have a little look. Learning objectives, really we're going to look at spine and brain. So spine, the indications and the choice of imaging in the assessment of neck and back pain. That'll be the first half. And the second will be on brain and the pearls and pitfalls in some of the GP managements of trigeminal neuralgia, hydrocephalus and brain tumours. So neck and back pain, I'm starting with this because it's by far the most common thing that you'll see from a neurosurgical perspective. So as you know, pain types, mechanical, musculoskeletal, central back or neck pain. And then you've got your radicular or neuropathic pain, that radiating pain from the nerve root, which goes down the limbs, typically either the arms or the legs, or very rarely across into the thoracic region. Degenerative etiology is by far the most common, multifactorial, genetic component, as well as general health, posture, body habitus, occupational activity, sports, and psychosocial issues as well. Management, as you all know, exclude the red flags, number one. Exclude significant neurological deficit, analgesia as appropriate, and physiotherapy and investigations. So the red flags, if we look at those, they can split them down into cauda-equina syndrome. This is probably the most litigated area. As you can tell from my accent, I'm from the UK. My mother's actually from Orange, and my family all moved here in the 50s. But then, unfortunately, I grew up in the UK and married to Britain. Took a while to come back. But in England, where I was the director of neurosurgery in St George's, we did a study on the most litigated area in medicine, and cauda-equina comes number one. So it's a very litigated area. GPs, unfortunately, are number one. And then number two is ED, number three is orthopedic, number four is neurosurgeons in terms of medical legal litigation. Acute back pain with sciatica, with any of the following. So any disturbance in bladder function, or perineal saddle sensories, or bilateral leg pain are red flags. And those are something that need to be taken extremely seriously. You need to get urgent scan and essentially send them to ED for assessment if they've got those problems. Disturbance in bladder is the main one that you're looking for, as well as numbness when wiping down below. Lots of people have back pain, have some disturbance in their bladder function though, and they'll describe that they've got some pain, related difficulty passing water. What we're talking about really is unable to pass water, or unable to feel when they're passing water. That's the real red flag. But obviously that can be a late sign, as can bowel function. So you've got to take it. If you've got a suspicion of cauda-equina syndrome, then they need to go to ED. Unfortunately, there's not one good clinical test to do. It's just an MRI. It's an investigation they need. Myelopathy, so typically describe numb and clumsy hands, as well as ataxia. Lhermitte's phenomenon, when they're bending forward, shooting pain up and down the neck. I know it's at first described in MS, but it's present with cervical cord compression as well. Upper motor neuron signs. Tandem gait is nice. I don't expect any GP to do a full neurological examination in the time you've got, but a tandem gait, or assessing the gait as they walk in. Tandem gait is that heel to toe walking. It's quite a nice, easy test to do without having to get out your pinprick and your cotton wool. You can also do Hoffman Romberg's quite easily with them standing up, popping their arms out, closing their eyes, and just making sure they can stand with their feet together. Look for Babinski's, we know, upgoing planters. Clonus, more than 2 beats is abnormal. Hoffman's, which is essentially easily described as a Babinski of the upper limb. So what you do is a little flick on the hand, if I can show you this from the hand, little flick on the hand, and you look for movement of that thumb. And that's another upper motor neuron sign. Spinal fractures, if there's severe central pain and a history of trauma or osteoporosis, we'll come back to that later. Cancer, a previous history of cancer, it says under the age of 20 or over the age of 55. Obviously, back pain is very common in over the age of 55. Inflammatory, so that's the MS or motor neuron, and infection. But really, with infection and spinal fractures or cancer, you're looking for that disproportionate amount of pain and night pain. Analgesia, paracetamol and NSAIDs, number 1. A weak opioid is a reasonable addition, and a very short course, just a few, 3 days, something like that, of low dose diazepam. Neuropathic analgesia, I used to, 10, 15 years ago, believe that we should have everyone who has radiculopathy should at least have tried on neuropathic analgesia. But actually, the evidence is increasingly weak, if anything. Yes, it may have a role in cervical radiculopathy, as you can see in the paper on the left there, but in lumbar radiculopathy, less proven. So it's an option. Warn them about cognitive side effects, drowsiness and sleepiness. Pregabalin I use for the younger age group, amitriptyline at night for the older age group generally, but it depends a little bit when the pain is. By the time you're getting into strong opioids, they really should have had investigation and you know what you're dealing with. So we could go, we gave away the answer there with a double click. What is the primary investigation of choice for neck, back pain, and radiculopathy? So we'll do the first MCQ quiz if we can.
Sorry, I'm just trying to relaunch the poll. Yeah, stop, wait. Relaunch. That should. Okay, you can answer those questions now. You see them on your screen? Can you see those results coming in, James?
I can't see the results coming in as yet.
Okay. You should be able to see the results when I share them in a minute.
Okay.
So I won't. We've got a pretty good click rate there, so I'll end it there and share the results. Can you see those now, James?
There we go. Yeah. Okay. So spot on. So the primary investigation of choice for neck, back, or radicular pain is an MRI. The difficulty is that number 1, the MRI may be precluded for financial reasons, and that's why probably most commonly I have patients refer to me with a CT. But the investigation of choice would be an MRI if you can get one. The spinal CT we can come and talk about in a minute, spinal x-rays, flexion extension x-rays, bone mineral density scans. So we'll go through those now, but really, back onto me now, hopefully. Yeah, the gold standard investigation is an MRI. So the other investigations we can talk about, spinal x-ray, flexion extension, bone mineral, spinal CT, SPECT CT bone scan. That's a really interesting one. I've got good feedback from GPs about that, and then nerve conduction studies. So spinal x-ray really has got a minimal utility. It's got poor sensitivity. It misses probably, depending on the imaging quality and the reporter, it misses something between 30 and maybe even 60% of spinal fractures. You can't make out any of the soft tissues to any great degree. You can't see any neural compression. So it's a poorly sensitive test. It can be used for follow-up imaging. For hardware, as you see here, there's a 2-level ACDF on the right that I did. So that's quite a nice use for it. You've already known your diagnosis. They've had their surgery. They've had a post-operative CT, and this is a follow-up imaging to make sure this patient had osteoporosis. So I just wanted to make sure there wasn't any wedging or anything, a progressive failure of the hardware, which there isn't. You can use it as follow-up imaging for a fracture, or you can use flexion extension to use for any significant instability, but really that's used after a fracture or discoligamentous injury. So you've proven already the fracture with a CT, or proven discoligamentous injury with an MRI. The other reason that you can use them is for allantoaxial instability, the rare cases of rheumatoid arthritis, which thankfully now we've got our disease-modifying drugs. It's becoming increasingly rare that we see really severe rheumatoid arthritis. Also see atlantoaxial instability with Downs. But really, spinal X-ray shouldn't really be used in general. Bone mineral density scans. So I think that to a degree, these may be underutilized. This is the RACGP guidelines. And this is for people over the age of 50 or postmenopausal women. Any minimal trauma, hip or vertebral fracture, they should be having a DXA or initiating on treatment for anti-osteoporosis, and be in consideration if there's minimal trauma fracture at any other site as well. So that's really grade A guidelines. Without any history of trauma, there's a grade D consensus opinion over the age of 70, or it's grade B if they've got any of these risk factors. And I think that you'll probably appreciate that most of your patients, or a significant proportion of your patients over the age of 70, may have one or two of these conditions: diabetes, hypothyroidism, on an SSRI. Those are just a few of them. And then obviously glucocorticoids, smoking, vitamin D insufficiency. So a lot of patients over the age of 70 certainly should be having them, in my opinion, and possibly younger as well. But really it's a screening test for osteoporosis and not for back pain or neck pain. Spinal CT, often used, and really because of financial reasons. That's why I think it's done most of the time. It's great for trauma. ED, brilliant. Shows up the bony pathology excellently. It is useful to show these pars defects. So the scan on the right, you can see, I don't know whether I can show a little cursor, probably not, but there's a little linear fracture. I wish I could show a cursor. It's just going to go forward. There's a little linear fracture through the pars, or pars articularis of L4. So that's the part of the vertebra between the articular facet above and below. So that's a pars fracture. That's a stress fracture. Normally occur, we think, at the age of about 10, 11, 12, but becomes symptomatic in the 30s, sometimes in 20s, 30s, 40s, 50s, around that kind of time. So yes, they're good for showing pars defects. Can show you ossification of ligaments, assess hardware or further assessments of tumor or infection once they've had the MRI. Or if an MRI is precluded, if they've got a pacemaker or other implanted devices, DBS. SPECT-CT bone scan. So these are the interesting ones. So this is something that essentially is a positron emission tomography. So it's giving a radioactive substance, technetium as usual, and you're looking for the breakdown of that proton-rich nucleus to emit gamma rays, and we detect the gamma rays in this positron emission tomography, and then fuse that with a CT to get good anatomical localization. And that really can help us highlight areas of active arthropathy. It can help us differentiate someone who's got, posterior thigh or lower back and buttock pain, differentiate between a lumbar cause or a sacroiliac joint cause or a hip cause, so trochanteric bursitis, for example. It can help guide the injection. So you get an MRI, which states that you've got a facet arthropathy, or more typically a CT, facet arthropathy at L2, 3, L3, 4, L4, 5, L5, S1, and sacroiliac joint arthritis, and maybe some hip arthritis as well. And it can help guide injection because it shows where there's a real activity in the arthropathy. So it's useful for neck and back pain. It's useful for leg pain if there's not significant neural compression on the MRI. It's useful for patients with significant spondylosis or generalized arthritis, and it's also useful for bone tumors. I wouldn't use it as a first-line investigation with MRI in someone under the age of about 35 or so, not to be used with pregnant ladies. And the reason, obviously, for pregnancy is the radioactivity, and the use in younger is because generally you're going to have a disc problem rather than an arthritic problem. But it's a great test, can really help guide your injections. So SPECT CT bone scan. Nerve conduction studies and EMGs used when there's predominant motor or sensory symptoms, rules out peripheral neuropathy or plexopathy, so brachial neuritis, ulnar neuropathy, carpal tunnel syndrome, common perineal nerve palsies, or sensory motor neuropathy. And it can help confirm a radiculopathy, but often when you request them, the neurologist or technician that's doing them won't do the EMGs that helps you confirm your radiculopathy. So you do have to make sure you refer to the right people. I think that the Sydney Neurology, Neurophysiology Service is brilliant, I have to say, as well as Neil Simon's group in Northern Beaches. Both of those groups are excellent. Other investigations, CT myelograms, so that's used for when the MRI is precluded and you suspect significant canal or intradural pathology. That's really going to be requested by a specialist. There's something called an EOS scan of the whole spine and lower limbs. They actually won the Nobel Prize for creating this, and it's really essentially an extended X-ray of to look at posture and to assess scoliosis. Spinal angiograms if there's something on the MRI that suggests a vascular anomaly, or an MR myelogram if they're suggestive of a CSF anomaly. But they're there to be used by a specialist. You know, there's not something you'll be requesting, but you may see them. They have been requested. So we can do some case histories. First was a 32-year-old mechanic, surfer, mountain bike racer, enjoyed weight training, had ADHD and bipolar, and had managed to cope with 3 months of pretty severe sciatica, but it had been increasingly severe with associated right S1 numbness and some mild weakness, difficulty standing on tiptoes. Quite a nice test. Standing on heels, standing on tiptoes. Again, you don't need to be getting your 2-point discrimination and your little cotton wool out. You can do just screening tests to see. So standing on tiptoes, standing on heels, and he had some weakness with that. Only drug history was on Ritalin and sodium valproate. So which investigations do you request here? You can do the next poll.
Okay, so I've launched the poll now, James.
So hopefully we can do this one fairly quickly.
Yep. Okay. Some different responses coming in, but I'm going to end it there in the interest of time, and I'll share those results.
Yeah, MRI. So that's right. This is a young guy. He doesn't present with predominant back pain. It's fairly acute history. This is an MRI. So that's what you want to be doing here. And he's got typical sciatic pain rather than just neurology, not just the S1 and weakness. And back to me, hopefully. Yep. So this is his MRI. It comes back as showing conclusion, right paramedian disc protrusion compressing the right S1 nerve root. So that's a right L5 S1 disc protrusion. You can see on the right there, compressing the right S1 nerve root. So what's your management? Further investigation, opiate analgesia, neuropathic analgesia, physiotherapy, CT-guided right L5 perineural injection, CT-guided right S1 perineural injection, CT-guided right L5 S1 facet joint injection, a pain specialist review or neurosurgical review. Remember, it's a right L5 S1 disc protrusion.
Okay. It's a slower response, this one, James.
Yeah, it's a tiff. They get tougher.
Got about half people, just over half have responded. We'll still come in quickly. Okay, I might end it there. And there you go. Can you see those?
Yeah. So further investigation, I agree. Opioid analgesia, I agree. Neuropathic analgesia, you could consider. I mean, you could consider some analgesia. Physiotherapy, yes, I think is reasonable. So right L5 and right S1, we'll talk about that in a second, and the facet joint injection now. Okay, we'll talk about those now. Where's that? So spinal anatomy, trying to simplify it. Okay, so on the left there, you can see the lumbar spine and the vertebra and the nerve roots coming out. In the cervical spine, you see the nerve roots and the vertebra. Most disc protrusions in the lumbar spine will be paracentral and will affect the descending nerve root, which you can see there. You see an L4-5 paracentral disc, which pushes on the L5 nerve. So you get the nerve below. If it's a foraminal disc in the lumbar spine, it will get the exiting nerve, which is the same as the nerve as the vertebra above. So most L4-5 disc protrusions will affect the L5 nerve root. And we saw that here, the L5-S1 disc protrusion was affecting the S1 nerve root. In the cervical spine, actually, most of your disc protrusions are foraminal or far lateral. And the way that it's situated anyway means that you're tending to get the exiting nerve. But because you've got the C1, 2, 3, 4, 5, 6, 7, 8, but only got C7 vertebra, it ends up being the same as that you end up in injecting the nerve with numbered below. So a C6, 7 disc protrusion will affect the C7 nerve. An L5, S1 disc protrusion will typically affect the S1 nerve, unless it's far lateral. So that's coming back to him here. And nicely in this one, it actually says L5, S1, disc protrusion compressing S1 nerve root, but they don't always say that. And sometimes the reports get it wrong as well. So next case history, a 38-year-old male chef, 10 years of lower back pain. He's had physiotherapy, chiropractic treatment. Oh, sorry, I just wanted to come back. I meant to say, to talk through the rest of it. So the correct answer, I think, for this gentleman, they were all very reasonable. What I would say is he had 3 months of pain. Normally disc protrusions will start to settle within the first 6 weeks or so. If you've got ongoing severe pain, he's also got ADHD and Ritalin and was less able to tolerate pain, but most importantly, he had some weakness as well. So he's got increasing symptoms, increasing weakness. He's tried conservative treatment for 3 months already. So yes, those other things are reasonable options, but I certainly think a neurosurgical review is the appropriate treatment at that point. Yes, you can refer a physio. Yes, you can try out neuropathic analgesia. Yes, you can do a nerve root injection in the interim. So 10 years of lower back pain, physiotherapy, chiropractic treatment, sports and exercise physician has seen him. His only previous medical history is bilateral meniscectomies. Drug history, he's tried some NSAIDs, didn't really tolerate anything else, and any other opiates, and nothing on examination. So which investigations do you request? We should be able to be fairly quick on this.
It's a bit slow. Oh, I've got some results coming in. It's a shame you can't see them coming in. Sorry, James.
The suspense.
We've got just over half, so I'll end it there.
Yeah, so we're getting increasing signs of the MRI. Again, the CT scan that you're saying because of financial reasons, I assume that's why we're saying he doesn't have a history of trauma. There's no hardware to assess. We don't think he's got osteoporosis. He's 38. Yes, he could have past defects, but really the investigation of choice would be an MRI. A SPECT CT bone scan, he's only got back pain, so I think that's not unreasonable. The only reason I would probably leave it is just he's a little bit young. but reasonable to add that in with the MRI. But certainly MRI would be the mainstay of treatment, of investigation. And so this is what it showed. You can see there, just when you generally look at it, it looks, fairly normal. There's a bit of disc degeneration at L4, 5. I imagine most of you see reports rather than look at the scans, and this report came back as disc degeneration at L4, 5, slightly more marked than 7 years earlier. Mild bilateral facet hypertrophy at L4, 5 without marrow edema. So in this patient, he's had ongoing symptoms. He's been appropriately treated conservatively so far, and there wasn't too much on his MRI, although it looks like the L4-5 is the problematic level. So I did go on to get a SPECT CT scan of him subsequently, and that did show and highlight that discovertebral degeneration in the inferior end plate of L4. So really, and the other levels of facet arthropathy were minimally active, and there was a bit of degeneration in the ribs, but not too much. Some in the sacroiliac joints, but really it was that L4-5. So he's got a bit of generalized arthropathy, maybe a little bit early, but really it's that L4-5 area. So what's going to be your management?
Okay, I've launched that one too. We're keeping on your toes tonight, everybody. Lots of questions to answer.
You can go to sleep in the second half of the lesson. Those people looking after kids or making dinner or trying to pour their glass of wine or whatever it may be.
Okay, we've got results coming through.
Okay, so really a CT-guided bilateral L5 perineural injection, CT-guided bilateral L4-5 facet joint injections.
We'll share the results there, James. Can you?
Okay, so I think that is very reasonable. Neuropathic analgesia, less evidence for central back pain, opiate maybe. Once you're starting opiate analgesia, he's had 10 years of symptoms. So, where are you going to go with this 38-year-old? Physiotherapy, I think, is very reasonable, but he's had it already. He's had lots of physiotherapy. He's seen exercise physiologists. I agree, not for perineural injections. He didn't really have radicular pain. Yes, the CT-guided L4 into laminar epidural is reasonable, and pain specialism for review, I think that's very reasonable. I can't see how many people said neurosurgery.
One.
We should have more. Always neurosurgery. Okie dokie. So I'm just going to talk briefly about the injections. So on the left, you see a transforaminal epidural injection. That's really your nerve root injection that you're looking at. You're targeting a particular nerve root which is being compressed. This interlaminar epidural injection is just basically looking to put steroid and local anesthetic around the theca. And then the third option was a caudal epidural, where and you can see that on the right hand side, where you're number 3, you're injecting at the sacral hiatus and hoping that this steroid is going to infuse up and then bathe the theca all the way up to the L4-5 level. So the difficulty here is that any of these injections that you're doing there for those radicular reasons are not really targeting the issue. Facet joint injections as well. He only had some minimal facet joint problems. So really it was all discovertebral, and this is a real problem issue. So I think actually this is very reasonable for a pain specialist referral. And he had been to see the pain specialist. I'll send him to the pain specialist. They did try facet joint injections and then subsequent radiofrequency ablation, but it failed. And he coming back to see me. And he had a lumbar disc replacement, and he did amazingly well. So lumbar disc replacements, I think, need to be used very cautiously. There are specific indications for that, and this is it. Someone young, someone who has tried all conservative treatment, including having a pain specialist review, probably had radiofrequency ablations and so forth beforehand, single level disease, high and hot on SPECT scan. So next is an 84-year-old retired male, 2 years of lower back pain, bilateral sciatica. He's had physiotherapy, significant previous medical history, AF, peripheral vascular disease, had a minor stroke a year ago, type 2 diabetes, total knee replacement, and he's on multiple medications, including apixaban. Had a stoop posture, no focal neurology, general restriction in his hips. So which investigations do you require? So he's 84, he's got back pain and sciatica and thigh pain. He's got general restriction of his movements in the hips.
Okay, we've got some results coming in. I'll just leave it another few seconds. Okay, I might. Oh, we've got 70% of people have answered. We'll end it there.
Well done.
Can you see those there, James?
Yep. Yeah, so I would agree. Bone mineral density scan, very well done, whoever said that. I would absolutely agree. CT lumbar spine can be useful. We've talked about the reasons that we do that. SPECT CT bone scan and MRI lumbar spine. I think I would do 1, 2, and 3 there. I think that's absolutely spot on. Bone mineral density scan, if he hasn't had one in the last 2 years, and a SPECT scan and an MRI of the lumbar spine, absolutely. And so this was the results here: grade 1 spondylolisthesis, severe facet arthropathy, severe central canal stenosis, bilateral recess stenosis, bilateral extraforaminal stenosis, L4-5 and L5-S1. And you can see that on the scan there, some severe canal stenosis. And the SPECT scan came back as showing this high activity in the L4-5 region, as well as some left ischial kind of bursitis, some minor rib arthritis and sacroiliac joint. Further management, so do you go for physio, neuropathic analgesia, bilateral injections, L4-5 facet joint injections, pain specialist review, caudal epidural, or neurosurgery?
Okay, we've got quite a few say neurosurgical review.
Yeah, and I think that's right. This guy's he's got severe canal stenosis. He's got 2 years of progressive symptoms. He's got stooped posture. Yes, you know, maybe he is a high-risk surgical candidate to a degree, but the facet joint injections and the perineural injections are only going to give him some short-term relief. So I think he needs to at least have a consultation with a neurosurgeon before he decided not to have surgery, if that was the way forward. So he really needs to be well informed of that decision. And he actually ended up having a posterior lumbar interbody fusion, which he flew through without any issues at all. So that's when you have the pedicle screws at the back, decompress the spine, remove that disc, which was problematic, and reduce the spondylolisthesis. I think, given for time, we may miss out this last case history.
Yeah, I think that's a good idea, James. Keep on to the next.
Noted, yeah, if it was someone with
condition.
canal stenosis. So that's the red flags: neurological deficit, significant pain, further investigation needed, imaging findings, neural compression. Little intermission.
Do we have time for that? I like
so facial pain. I have given a recent talk on this, so I am going to go through this fairly swiftly. I think it's still on the website, is it?
It is still on our website. It's called Headset. So if anybody wants to watch the whole presentation, you can, but you can give a summary now.
So I specialize in like I've told maybe 1 or 2 of you here, a liberator of nerves, whether they be in the spine or in the brain. And so I do specialize in trigeminal neuralgia. And most facial pain, though, has maxillofacial ENT causes, dental, temporomandibular joint, sinus disease, few rare conditions there. Giant cell arteritis is the one that you mustn't miss, feeling over the temple, ESR and CRP. Ophthalmological causes, glaucoma, and then the neurological ones, either the trigeminal neuralgia, which is primary, which is the one neurovascular compression of the trigeminal nerve, typically by the superior cerebellar artery, or secondary to a tumor, or you can be secondary to MS or neuropathic type pain. Need to be differentiated by trigeminal autonomic cathalgia. So with trigeminal neuralgia, it only affects half of the face, and typically in 1 dermatome or 2 dermatomes predominantly. Very typically starts in the nasolabial fold, sometimes the jaw, sometimes around the eye. Cluster headaches a bit more around the eye. And these trigeminal autonomic cathalgias typically have an autonomic feature with them: redness, severe tearing, sweating, or you can get that paroxysmal hemicrania continua. Other causes: cervicogenic headaches, typically occipital neuralgia. But really, trigeminal neuralgia it's a it's that sharp, sudden, lancinating paroxysms of pain lasting maybe 2 or 3 seconds, really severe. You have bouts of severe, sudden pain. And there can be a grumbling background of more chronic burning pain, but it's really that sharp, sudden, severe pain in only one half of the face, typically around the nasolabial fold, but it can be eye or down around the jaw. Often there's dental causes suspected at first. Initial assessment there, we've talked about a few of these things. This is helping differentiate between some of the other trigeminal autonomic cephalgias with cluster headaches and hemicrania. The length of time, really duration, 15 minutes for a cluster headache. That's not trigeminal neuralgia. 2 minutes, 5 minutes, continuous hemicrania. So that's not trigeminal neuralgia. The short lasting unilateral, lasting between 1 second, but normally it goes up to maybe 10 minutes or so. Again, not trigeminal neuralgia. And particularly you're then looking for that autonomic features with. So what's the investigation of choice for trigeminal neuralgia? Have you got this one?
I think I've messed up and I don't think I've got that question. Oh, okay, wait, no. I do actually. Where we go.
All right. If you don't, that's absolutely fine.
I do.
So, none, CRP, ESR, OPG, CT sinuses, SPECT CT cervical spine, looking for cervicogenic pain, MRI brain with Fiesta sequences, MRI cervical spine. Or none, or other.
There's a whole range of answers coming in, James. So,
yep, good.
We'll just give it another few seconds.
There are no wrong answers, except for the answers which are wrong.
Okay, I might end it there. And there you go. Can you see those now?
No. Okay, so CRP, ESR, you've got to rule out giant cell arteritis, not unreasonable at all. MRI brain, very reasonable. So Fiesta sequences, these are fast acquisition sequences that are really looking at high resolution, which is what you need. You need an MRI with high resolution, looking particularly for trigeminal neuralgia. Often I'll get referred patients with trigeminal neuralgia who have had an MRI brain, which is being described as normal, but it hasn't looked for trigeminal neurovascular compression, and they haven't got the sequences with enough resolution. So if you're going to ask for an MRI brain, ask for it with Fiesta sequences or high resolution, looking for neurovascular compression for trigeminal neuralgia. I would agree with none, because it's a clinical diagnosis. And even if the MRI brain is normal, as I've just said, there may be neurovascular compression. I would also agree with other, which we'll come on to in a second. So this is an MRI brain with the Fiesta sequences. The yellow arrow is the trigeminal nerve coming from the brainstem, and the red arrow just shows that superior cerebellar artery. So this was with particular high resolution imaging, and you can see how difficult it is just to see that even with this, what I've highlighted. So a normal scan does not mean no neurovascular compression, but on the other hand, neurovascular contact may be entirely incidental. So it's a clinical diagnosis. So what's the treatment of choice for trigeminal neuralgia? Amitriptyline, baclofen, carbamazepine, gabapentin, indomethacin, lamotrigine, oxcarbazepine, or pregabalin. I think verapamil is on the end, which I can't quite see.
Okay. A mixture of responses coming through. The most popular seems to be carbamazepine.
Excellent, which is the right answer. Yeah, so carbamazepine is the right answer here. I'll talk about those. So all those others are second line, third line treatment. Once you're getting onto second line or third line treatment, they should be seen by a specialist. And carbamazepine is the treatment of choice. It's gold standard. And interestingly, it's not only the gold standard, it's also therapeutic as well. So it's not only treatment, it's also therapeutic. And by that, that's why we come back to other. actually giving carbamazepine, and if they respond to it well, it's almost diagnostic as well. So it can be used for a diagnosis of this as well. Adverse effects of carbamazepine that we need to be aware of: hyponatremia, ataxia, diplopia, confusion, bone marrow suppression. We'll miss this one out. Teratogenicity, liver toxicity, and Stevens-Johnson syndrome. The answer is all of the above. So you do need to check their bloods. You need to look for, check their sodium, check their platelet counts, white cell counts, hemoglobin, and also advise them about rashes and to seek medical attention if they occur because of SJS. So when to refer: when it's suspected or diagnosed, if carbamazepine is no longer tolerated or effective, and if the MRI is normal, or if it shows neurovascular conflict, or if it shows something else. So essentially, whatever the MRI brain shows, if the first two are fulfilled, one or the first two are fulfilled, then refer on. The reason to get the MRI really is to make sure you're not missing a tumor or MS or some other condition. And then for me to look at neurovascular conflict. So this is just a couple of operative photos. So you can see the blood vessel, the actual main blood vessel, superior cerebral artery, it comes in from posterior, from deep to the nerve, which you can just see there. And so you push the Teflon through, manipulate, free up the nerves to sick them out from the vessel, and then place the Teflon felt after freeing up the blood vessels. So I do both. Some people just put the Teflon in, but I free and make sure I've carefully freed up the whole of the artery along from that nerve, so there's no ongoing compression. And this treatment here is 90% effective in the immediate setting, with results after about 10 years being at 80%. So there's about a 10% recurrence rate over 10 years, but the vast majority of patients wake up pain-free. So yes, it is invasive, but it's a great treatment. Very brief interlude because we've got about 5 minutes left, so I'm going to run through this really quickly. Symptoms of the brain tumor, I think we'll know all of these: vomiting, headache. Actually, we did a study with Professor Back's group showing that cognitive changes is the actual most common for primary brain tumors, gliomas, glioblastomas, although most people reported in the ED or by the general practitioner or neurosurgeon to be presenting with focal neurology. Increased intracranial pressure, this is what you need to know about and be aware of: the vomiting, the headache, particularly a morning headache or headache when you're lying down. Looking for papilledema if possible. I know it may be difficult in your clinical settings. Really, the changes in vital signs and Cushing reflex, that's an end stage problem. That's seen in patients who are moribund. So that's not something you're going to see, hopefully. So I've got a case history here, which we'll go through quickly. A 78-year-old, 10-day history of headache, ischemic heart disease, nothing on examination. He's had his bloods and they're all normal. MRI is the gold standard investigation. And just for the reports, we're going to just briefly talk about here which of the following require urgent review for this gentleman. So you get the report back. If it shows arachnoid cyst, pineal cyst, colloid cyst, dermoid or epidermoid cyst, brain abscesses, tumor cysts, all of the above, which ones of those need urgent review? In this 78-year-old who presented with a short history of headache.
Okay, the most popular response is all of the above.
Yep, I'd agree with that. And the reason being is his symptoms. You know, he is symptomatic with a headache. It's not usual for a 78-year-old to turn up to a GP who's otherwise well and say, I've got 10 days history of headache. And there was no obvious cause. His blood pressure, etc., was normal. So if you see something on the scan, we've got to suspect that may be the cause. Arachnoid cysts, almost always incidental finding. They're developmental, rarely, very, very rarely. I think I've operated on one in my career, require any intervention. But you do need to counsel the patient that they are increased risk of intracranial hemorrhage. They're often detected maybe in younger patients, so that may be involved in contact sports. So I just have that conversation that, you know, you may be at theoretical risk of increased intracranial hemorrhage if you were to have a significant head injury. Pineal cysts, again, incidental, rarely requiring the intervention. That little news article on the right is thanks to one of my colleagues who is now got restrictions on their APRA, who is courts the news quite frequently. So pineal cysts are incidental, developmental, and very, 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 very rarely require any intervention. The important thing is they need to be differentiated from a pineal tumor. And that can be done from the scan appearances themselves, or with follow-up, or with contrast imaging, or a combination. Colloid cysts, yes, these are developmental. They occur just at that third foramen of Monro, but they can slowly enlarge. We're not quite sure about the etiology of them. These are really important. These can cause sudden death. If you see colloid cyst on the scan, even if it's 1 or 2 millimeters, you need to ask for neurosurgery review. And certainly in someone who's got headaches, you need to be getting urgent neurosurgical review. Dermoids and epidermoids, these are again developmental. They grow very slowly, linear growth rather than exponential growth like tumors. They can resemble arachnoid cysts though. Brain abscesses, obviously, they're important and need to be referred on. In this case, it was actually a left temporal lesion which showed solic and hemorrhagic components, and differentials included high-grade glioma, primary tumor, or metastasis. So 78-year-old with one or the other. What's your management? I'll go through that very briefly because we've only got 10 minutes left. So stop Cartier, absolutely. That was brilliant of the GP in this case, who did that straight away, and urgent neurosurgery review. And the GP kindly was amazing on this case. John Hannon, the phenomenal, organised the CT chest, abdomen and pelvis. I got dermatology review, and it did end up being a melanoma, which is exciting. He's on the new immunotherapy treatments, which just work amazingly. He's a very fit and well gentleman, so I hope that he's going to do really, really well. Interestingly, he had one of these disappearing lentiginous melanomas in retrospect about, I think it was 5 or 10 years earlier. Hydrocephalus, we're going to do this in about 1 or 2 minutes. Communicating or non-communicating. Non-communicating means obstructive, and that really needs to see a neurosurgeon unless it's a developmental and long-term finding, in which case we need to decide whether it's been there all their lives and just an incidental finding. And I get ophthalmology to review to determine papilledema, whether it's chronic or acute, or if there is any, and to monitor for the future. Communicating, post-hemorrhagic carcinomatosis, that's end-stage cancer, post-meningitis. The main one here that I wanted to briefly talk about was normal pressure hydrocephalus with your triad of wet, wacky, and wobbly. It's when you get a disproportionate increase in ventricular size to cerebral atrophy. It occurs in the elderly, but the actual pressure within the fluid is normal, so normal pressure. And you get that urinary incontinence, dementia, and gait disturbance. Because there is no definitive investigation, it's a combined review with neurology and neurosurgery. We don't want to be putting in shunts in people that may have Parkinson's or other causes for their unsteadiness or dementia. But the shunts do work really well, particularly for gait disturbance. Unfortunately, less well for some of the cognitive changes. But if you catch it early, which we tend to in this, some of these, excellent GPs, that it can be really effective. Cerebral aneurysms I get asked about a lot. I refer them essentially almost always now for the endovascular services. If you do want to know an aneurysm risk calculator, I've got one there on the right. But once you're seeing an aneurysm, I'll be referring on to the endovascular team. Most of the aneurysms can be dealt with either with surveillance or with coiling if necessary. And then the very last slide here is some of the amazing cutting edge technology we've got. New fiber tracking, so this enables us to delineate the white matter tracks. We haven't been able to do that before without having a neurosurgeon, a radiologist, and medical physician work on it for weeks. We can now do it within a matter of minutes using AI. And this is an intraoperative image I've got here of an MRI done pre-operatively and uploaded onto a computer system. The blue is a glioblastoma which has recurred in Broca's area. Patient had been declined further surgery because of the eloquent area and nature of the location, came then referred to me for a second opinion, and using awake craniotomy, so being able to do intraoperative monitoring with speech and language therapists, and being able to map out these white matter tracks of all of the language, which you can see in green here, with the motor tracks, which you can see in the dark blue there as well. I was able to entirely resect the tumour. Yes, it was a glioblastoma which had recurred, but he was able to live another extra year of his life, for which he and his family were extremely grateful. So there's the conditions, a whistle-stop tour, and we've got about 5 minutes left for some questions.
Okay, thanks, James. I've just realised I can't launch these evaluations tonight, so I'm going to send those out by email tomorrow. Apologies for that. So if you could look out for that email tomorrow, that would be appreciated. I entered all these other poll questions and those ones didn't work. We've got one question here. For spinal issues, how do you decide between neurosurgeons and orthospinal surgeons?
Yeah, well, you don't have to, you refer to the neurosurgeon. No, so the serious answer is, in general, they have slightly different skill sets. A lot of the neurosurgeons in training will have spent each year doing about half of their surgery would have been spinal in nature. Orthopedic spinal surgeons often will specialize just in their final year or in their fellowship year. So in general, they have maybe got slightly less throughout their training, but there's a slightly different field. So orthopedics, I refer to for my pediatric patients, my pediatric scoliosis patients. And they are particularly good at deformity correction. That said, for the adult scoliosis deformity correction, I think probably the best in the field would be Dr. Yannis Sagides, who I refer my patients to. So they've got complex scoliosis in the adult population. I refer them to Dr. Sagides, who's a neurosurgeon in training, but he's also done some orthopedic training as well. And then if they are pediatrics, I refer them to the orthopedic spinal surgeons. But we work very closely together, and hopefully that question is not going to be so relevant in maybe 5 or 10 or 50 by the end of my career, let's say that, because we will hopefully have managed to merge the two together. And we're merging more and more with meetings together, and so hopefully in the future that won't be such a question, but certainly pediatrics to the orthopedics, and then otherwise I think if you're looking at neurological neural decompression, then neurosurgeon, certainly.
Okay, thanks, James. I can't see any other questions here. Has anyone got any questions for James? You're welcome to unmute yourself and ask the question with sound, or you can type it in. Everyone's gone quiet, James.
I've bamboozled them with too many questions. They're finding out managing to eat their dinner or put the kids to bed.
Possibly. No, we're just scrolling through.
If you do think of questions, feel free to contact me either via Wendy or via my practice manager, Meg. I'm more than happy to answer questions. And Wendy, I'm sure will send out my details.
Yep. I'll send your contact details tomorrow in the email that I send out. Just to remind everybody, you've got rooms at North Shore Private and as well at DY. So you can service those two areas well. Sometimes for some of the specialised things you do, you have people travelling from further afield, though, don't you, James?
Yeah, absolutely. Yeah. Some of them all over New South Wales and Australia.
Yeah.
Which, yeah. Not quite the same when I was in the UK. I used to have people traveling from Dubai and from India and places like that, Germany, France and places. But the geographic distances are probably about the same.
Yeah, very similar, aren't they?
It's probably going to be about the same.
It's the world's a very big place at the moment with all of our border closures, etc. Yeah. All right, I can't see any more questions. We've got a few thank yous coming in, which is nice.
Lovely. Thank you very much.
Nice to see you all. So thank you very much for your time, James. And as I said, this session's been recorded. So if you missed some or you'd like to share it with your colleagues, I usually edit it. It takes a week or so for me to get it up on our website, and it will be available there. All of our recorded sessions are on the GP Education page under Always On events. You register for the session and then I email you the link to watch the video of the recording. So Yes, thank you everyone, and look forward to seeing some of you hopefully face-to-face in the new year. So we'll end the session there. Thank you very much, James, and thanks everybody for your attendance tonight.